Morning to everybody. Thank you so much. I'm extremely honored to be here in front of all the pioneers. Passionate talks by Dr. Amita, Dr. Monil, and Dr. Rita. And I'm a little nervous today for the first time after a long, but I hope you will enjoy my presentation. I'm going to discuss regarding interesting cases in neurovirology. I'm Dr. Neha Gupta, infectious diseases physician, and I'm also founder of NG Swastha, which is our initiative for creating awareness regarding infections in the community. So we all know that CNS infections, of course, nowadays is increasing, and they can be because of various etiologies. It can be bacterial, mycobacterial, fungal, as well as viruses, which is the focus today. And depending upon which part of the nervous system is involved, whether it's the brain or it's the spinal cord, the presentations can be myriad. And the presentation also depends upon the immune status of the host. As if there is a delay in the diagnosis, there can be significant mortality. We have seen it. So all attempts should be made for an early diagnosis of infection so that we can start an early appropriate therapy. So when we discuss the various complications of the neurotropic viruses, we have seen Dr. Amita talking about this earlier. So most commonly we have encephalitis, meningitis, as well as acute flaccid paralysis, and sometimes even PML. And when a patient is presenting to us, how do we approach? So most important as a clinician would be to give or take a detailed history, which will include symptoms and their onset, duration, and progression. It's important for us to classify that what is the patient presenting to us, whether it's a meningitis, encephalitis, or is it a systemic encephalopathy. And how do we do that? Very basically, if suppose the patient is having meningitis, there will be initial symptoms which will be predominantly headache and vomiting, and then later on there will be altered sensorium. Whereas in case of encephalitis, since it's inflammation of the brain parenchyma, the neurological dysfunction will occur earlier. Also, we have to differentiate it from the other causes like the post-infectious ATEM as well as the NMDR encephalitis. Why is it important? As Dr. Amita has mentioned that it can be because of various etiologies, but based on what is the syndrome, we can also predict the etiology. The etiologies are different. However, of course, there is an overlap between meningitis, encephalitis, and the encephalopathy. So let's begin the first case of this virus-brain interaction. This is a 47-year-old gentleman. He's a farmer, and he presented to us in 2008. He was complaining of involuntary movements, which started off in the right upper limb, followed by left upper limb, and they were chorioethenoid movements, which developed over a period of 18 months. There was no fever and headache. Now he was also complaining of some changes in the speech, cognitive decline. The MMSE was 21/30. There was significant weight loss. There was also history of VZV twice in the past. And in 2006, he had a right-sided hemiparesis, which was sudden onset. He was diagnosed with HIV, with HBV co-infection, and the CD4 count was 371, and the viral load is close to 4,000 copies. And this is the MRI of the patient. Now, an ID reference was called, and the anti-toxo IgG we had also sent, which turned out to be positive. As a part of the baseline evaluation, the VTRL TPHA was done, which were negative. The chest X-ray and the ultrasound were negative. The CSF, the cytology, they were not really telling us any particular etiology. Now, with this history and the investigations and this MRI, what is the likely diagnosis? Is it because of toxoplasmosis, MTB, HSV, or is it hand? Anybody from the audience? So what do we see here on the MRI? We see significant cerebral atrophy. There is prominence of the sulci, and there is also these prominent hyperintensities which are seen in the thalami, and this intensity which is seen. So this fact, so toxoplasmosis can result in movement disorder, choriothenoid movements. However, in the MRI, we will see space-occupying lesions, which will be in the basal ganglia. Here, there are no space-occupying or are ring-enhancing SOLs. MTB, usually it will present with leptomeningeal enhancement. There will be basal meningitis, which was not seen in this patient. Plus, history-wise, there is no history of fever. Usually, the patients will have constitutional symptoms of fever, headache, vomiting. So this was also absent in our patient. What about HSV? Again, this is a history which is happening over a period of almost 18 months. And the MRI is also not suggestive of HSV. So clinically, history-wise, it's not matching. So that is why it is likely hand in this patient. And hand is actually seen in close to 30 to 50% of the patients who are living with HIV. And it can result in cognitive decline, behavioral, as well as the motor deficits. So we were lucky to publish, this was our first case of HIV who presented with movement disorder, and we were able to show that with effective antiretroviral therapy, there can be a response in the neurological manifestations. Now, this is another aspect which is very interesting about HIV and, of course, the neurological manifestations. So what is true in this patient? HIV directly affects the neurons. Activated brain macrophages and the microglia release products which attribute to the cerebral volume loss. Antiretroviral therapy with low CP score increases the neurocognitive impairment and should be avoided. All the above. What is true? Anyone? Okay, so let's take up the first one. Is this true? HIV directly affects the neurons? So this is interesting that HIV directly affects the hepatocytes, but it does not directly affect the neurons. What happens is, when HIV the virus enters into the brain, it irritates the astrocytes and the microglia, and they release the chemokines, which then further cause destruction, and that is responsible for the cerebral volume loss. And that is why in most patients with HIV, we see a significant cerebral atrophy. What about the, So another important aspect of this HIV infection and the brain is that HIV has this innate, it can attach to the receptors on the circulating leukocytes. Now, HIV virus uses the infected leukocytes like a Trojan horse, which then crosses across the blood-brain barrier, and then subsequently it can result in proliferation and the various other neurological manifestations. But the antiretroviral therapy, it cannot cross the blood-brain barrier effectively. That is why there is sometimes even there can be chronic and persistent replication, which may continue despite the systemic viral load being undetectable. And this may also result in resistance as well. So it's important when we are choosing drugs for the HIV that they should be also having good penetration at the site of infection. And that's why there was this concept of CPE score. And initially it was thought that we should be using drugs like zidovudine and lamivudine, which have got high CPE score. However, this is a little under clouds, and it is now being mentioned that although the CP score is taken to indicate the capacity of the antiretroviral therapy to penetrate into the CSF, but it may not always accurately reflect the ART concentration, and efficacy in the CNS. So the currently approved drugs, which is the TAF and the TDF, along with the DTG. So TAF, TDF have got a low CP score, but this combination is good and effective in controlling the viral replication in the brain as well. And even the dual therapy for HIV, which is now being used, has also been studied that even this is able to have good effective viral load suppression. Now I will, how much time do I have? 4 minutes, okay. So this is a 38-year-old gentleman who was a kidney transplant recipient, and he was on TAC, MFF and steroids, and subsequently he developed this acute rejection for which he received the methylprednisolone pulse as well as the MMF was increased. He was not on TMP, SMX, INH, fluconazole or valganciclovir prophylaxis, and a month later he presented with altered sensorium. Now what do we see here in the MRI? There is a tiny hemorrhagic foci on the anterior aspect of the left and lentiform nucleus, and there is prominence of the cerebral cerebrum. Now in this patient, when we examined, examination is very important, the vital signs were stable, but this is the clinical examination of the lips. There were lesions, there were vascular lesions here on the lips, as well as the patient had perianal HSV. So this patient was presumed to be having HSV encephalitis, and IV acyclovir was initiated, to which he responded. So whenever there is a case who's presenting with altered sensorium, it's important that we know that whether it's encephalitis or not, and this is a beautiful document from the IDSA which describes the algorithm as well as the case definitions. Now I have this third case, which is an 8-year-old boy. He presented with emotional lability, drowsiness, dystonia, and there was this left leg weakness. Now MRI showed bilateral thalamic lesions, and there were no lesions on the temporal lobes. What do you think is the diagnosis here? So this patient had this CSF LIZ IgM positive for Japanese encephalitis. We can also do the PCR, but PCR has only 50% sensitivity. And it was really an honor to know, sir, that you were the one who introduced or innovated this. So this slide which differentiates Japanese encephalitis and the herpes simplex encephalitis. Japanese encephalitis predominantly involves the thalamus, basal ganglia, as well as the brainstem. And it usually can present with LMN weakness, whereas with the herpes simplex encephalitis, it is predominantly the temporal lobe as well as the cingulate lobe. And this is one of the interesting cases as well. This is a 37-year-old gentleman who had the severe pain in the left ear. Then he started having headache and had to be hospitalized. Then he was having on the MRI, there was meningitis, and as we can see here, there is this lymphocytic predominance with aseptic meningitis. He subsequently developed this left intranuclear facial palsy, and an ID reference was given. So what do you think it is? He was having severe pain in the left ear. So he had, when we examined, he also had certain vesicular eruptions here. This was shingles or herpes zoster, which presented as meningitis. So usually encephalitis, but VZV also has meningitis as the presentation. The CSF biofire was done, which detected varicella zoster here. For making a diagnosis of neurotropic viruses or the etiology, there's a battery of tests which we have to perform. And all of this, it's very important to send the sample appropriately, and it should be clean collection and quick transport. A word about this meningitis encephalitis panel, which has become one of the standard of cares for a patient who's presenting with meningoencephalitis. But remember that certain viruses like the Japanese encephalitis, KFD and Nipah cannot be really picked up on this. And I think in the interest of time, I'll summarize. This was another patient with 40-year-old gentleman, diabetes, and he presented over a period of headache, fever for 1 month, and this was the MRI which showed that there is encephalitis. The CSF biofire panel which was done was negative here, and if we look at the analysis, it was showing lymphocytic predominance, and there was hypoglycoria. But this, the CSF to glucose ratio was low. So what do you think it is? This is a patient who is diabetic and is presenting with headache fever for 1 month. The MRI is not showing any leptomeningeal enhancement, but there is encephalitis, which is mentioned. And the biofire panel is negative. So in this particular patient, the CSF crag was done, which was positive. So remember that biofire panel, multiplex PCR, can miss out cryptococcus. Even though it has it, but it can miss out, and it calls for caution for us clinicians when we are dealing with, or when we are interpreting such reports. And of course, the Cryptococcus neoformans grew later. So I think managing infections is a multidisciplinary collaboration, and it's very important that all of us speak to each other. We need to speak to our microbiologist, clinical microbiologists need to speak to the clinicians, and this will definitely help in better patient management. Thank you so much.